السلام عليكم ورحمة الله وبركاته. مساء الخير مشاهدينا الكرام في سلسلة محاضرات فن الاستذكار التي نهدف من خلالها تبسيط وتسهيل أشهر المواضيع الطبية التي يدرسها جميع طلبة التخصصات الصحية، وسيتم استقبال جميع الأسئلة بعد الانتهاء من المحاضرة. كانت معكم وجدان النهدي. والآن نرحب بدكتور عبد السيد، طبيب طوارئ في مدينة الملك عبد العزيز بجدة. أهلا فيك دكتور، وشكرا جدا لقبولك الدعوة.
في التم الصحة والعافية والسعادة يا رب. سعيد أن أكون معكم، سعيد جدا بالاستضافة. يا رب الله يكتب على يدينا إن شاء الله ويديكم إن شاء الله الاستزادة بالمعرفة واكتساب العلم والخبرات بإذن الله.
تفضل دكتور، شكرا المحاضرة.
الصوت واضح؟
أيوة واضح.
طيب، بسم الله الرحمن الرحيم وبه نستعين. Today our topic, our lecture is gonna be about how can we make the chest X-ray interpretation, or how can we read the chest X-ray in a systematic way. First of all, my name is Abdul Saeed. I'm an emergency medicine resident, R4 in King Abdulaziz Medical City National Guard Hospital in Jeddah. I'm here because I love to educate, to inspire, and to make a positive change. This is our objective for today. First of all, we will talk about some basic chest X-ray. Then we will talk about systematic approach to how can we interpret chest X-ray in a systematic approach. Then common pitfalls in radiological interpretation. Then we will talk about some cases and some radiological findings. So, how can we read such a thing? There is multiple systematic pathway, systematic approach you can interpret, or you can read chest X-ray on it. But first is first. We are not dealing with an image. We are not dealing with just the pictures. We are not dealing with radiological findings, and that's it. We are dealing with the human being. We are dealing with the patients. We are dealing with people that they have a lot of things other than we are diagnosing pictures or radiological findings. For that, history and physical exam should influence your interpretation in every time you are about to read or you are about to interpret chest X-ray or any radiological finding or any lab investigation. Majority of the resident, majority of the interns, medical students, they are saying multiple times, how about chest X-ray? We are not catching a lot of stuff from it. We are not catching any benefit from it. Let's do a CT scan for that patient. Let's do a CT scan. CT chest. What's gonna give us a lot of value. It's gonna give us a lot of results. But we cannot scan a lot of patients. I'm gonna tell you one secret. If you can interpret, if you can read the chest X-ray in a systematic way, you can gain a lot of things about the patient. You will know a lot about your patient. You will know a lot of about your patient disease. First, this is just a 3D dimension, 3D dimension of the chest. I catch it from Zygote Betty, which is a website that gives us many 3D pictures. It shows just and vertebrae and upper extremities. And this is a cross section of the chest from the upper part, and yellow line that indicate this is a different level we can cut and we can inspect the chest from it. And this is sternum, as we can see on the CT chest. We start by interpreting chest X-ray by reading the CT chest. No, we are comparing how can the anatomical findings, how can the basic anatomy, we can learn it from the CT scan compared to the chest X-ray. I'm gonna show you in the next few minutes about a lot of values we can catch it from chest X-ray. This is anterior aspect. This is anterior picture or coronal image from CT chest. This is sternum. This is the junction between the cartilage and the sternum. And this is, first of all, we're going to start about one of the common misinterpreting or misreading. I cannot say the chat, but always a lot of residents, a lot of physicians, a lot of interns, medical students, they are reading that reps with a yellow arrow that show the bottom edge of this reps. Always we are reading that reps as posterior reps, which is not true at all. This is the anterior reps. Always we are interpreting or we are reading this as anterior, as a posterior reps, which is not true. This is anterior reps, and we can assess the inspiration, or we can assess the quality of chest X-ray or the expansion of the lung by counting the anterior reps. At least for any chest X-ray, at least we have to count at least 6 anterior reps, maximum to 8, 9, but at least 6. And this is a posterior picture for the CT chest. Also, it showed the posterior, showed the spinous vertebrae, and this is the left clavicle, as it showed on the yellow arrow. We came back, as we are reading that always as anterior reps, which is false. It's wrong, not true. This is a posterior reps, which is showed by the yellow arrow. The yellow arrow, it showed the upper part of the posterior reps, the upper edge of the posterior reps. Here it's gonna be clear. This is a posterior reps. This is not an anterior reps at all. This is one of the most common misinterpretation or misreading for the chest X-ray. I want to just to highlight it initially to make it clear for everyone. There is a lot of misreading and common misinterpretation. We're gonna stress on it. We're gonna emphasize it later. Some of you, they're gonna say, how can this is anterior? This is the previous one was anterior reps. This is the posterior reps. I'm gonna show you in this 3D. On this video, it showed that the posterior reps is slightly start to be more up, then it gets down to be more vertical or not that much horizontal. This is what we are misinterpreting as posterior reps. And anterior reps, it's come down. It's not more and it's not more horizontal like the posterior reps. The posterior reps, it start more horizontal, then start to be more vertical. على النقيض تماما على الانتيريور ريبس. الانتيريور ريبس دائما بتكون start to be more vertical. As we mentioned before, rib counting is so crucial. We can assess the always we are taking the chest X-ray in full inspiratory phase. We are asking our patient to take a deep breath. Then we are asking them to hold their breath for seconds. At that time, we will take the X-ray. We mentioned before, at least 6 anterior ribs, at least 8 posterior ribs. We should count it to say this is a good and full inspiratory phase for the chest X-ray. Why we need full inspiratory phase? Why we need to count to have this limit of ribs? Because we need full expansion of the lung. We need the air on the lung to show that the lung structure and the area in the front of the lung, like sternum, ribs, and anterior ribs, and posterior ribs, and the vertebrae, and the cardiac parts. This is the clavicle. It should be appeared on every chest X-ray. It should be appeared in every chest X-ray. And it should be equidistant. The clavicular heads, the two clavicular heads, it should be equidistant from the spinous process. This is one of the most misreading or misinterpretation on chest X-ray. We said the chest X-ray is well centralized upon what? Upon the trachea, which is wrong. The trachea is a mobile organ. We cannot comment on it, and we cannot comment on the centralization, what we call centralization or rotation upon the trachea, because sometimes the trachea is slightly deviated to the right side, which is normal. But we can comment on a fixed organ or fixed bony elements like what we are doing right now. The spinous process, it should dissect, or it should be equidistant from the two clavicular heads. But this is a second thing. We are misreading that chest X-ray. We are saying this patient is centralized. We are not commenting on centralization more other than we are comment on the rotation. As we mentioned before, if the chest X-ray is slightly rotated to the right side or the left side, it's gonna give us the area behind the sternum. It show more laterally other than to be more anterior. It's gonna we're gonna misread it. We're gonna misinterpret it because it's not well centralized, which is not acceptable. Sometimes not acceptable rotation. And as we mentioned before, minimal rotation, it will give you a false picture, or it's gonna give you a false chest X-ray. Other than this, scapular area, or the scapula, and the medial border of the scapula should be appeared, but it should be in contact with the lateral borders of the lung. Always we are misinterpreting the scapular border as there is an element of pneumothorax, which is not right, and the usual position or the right position for the scapula, it should be on contact with the lateral border of the lung. And always we are asking our patient when we are doing the chest X-ray and sitting position or standing position, we are asking them to hug the cast to allow for a minimal rotation of the scapula or external rotation of the scapula. Also, the humerus head and the part of the humerus that should appear in every chest X-ray to say this is a full picture of the chest X-ray. Then we're gonna comment on the vertebral area or intervertebral space. As we mentioned before, we should have a good. We should comment on the penetration upon the vertebral appearance. We say this is so white and this is so blackish. This is overshooting, this is over penetrating, or lower penetrating. How can we assist for that? The vertebral bodies should be appear at least down to the T4, the thoracic vertebra number 4, to say this is a good penetration. We didn't want to be that much clear to assess the vertebral body. No, this we can assess it on the vertebra or the thoracolumbar X-ray, but we can accept just the whole bar to be a little bit appeared on the chest X-ray. This is the spinous process, which is a crucial bony part on every chest X-ray. This is from the lateral area. Why I want to stress on the spinous process? Because a lot of things we should comment on it upon the spinous process. One of them is the rotation. The heart and different part of the heart is overlapping each other. For that, we cannot comment on it on the chest X-ray in a clear way or in a good way, but we can have a small hint. We can have a good interpretation about the heart size, the diameter, the borders, the area in contact with the heart. As we can see this X-ray, we can read it as what we call it is rare disease, which is sciatus infarctus. The normal heart is lying on the left side, slightly rotated to the left side, but on those type of people, their heart lying on the right side. They are in contrast to the normal people. But as we can see, the marker on the left upper of the part of the screen showed that the L is flipped to the wrong place or the wrong direction. But this is a normal X-ray for a man that the X-ray tech or the radiological tech make the L flip to the other face, and this is the X-ray. I brought that because the mark is something is fundamental and so important in interpreting every chest X-ray or any radiological finding. Use a marker as a guidance. How can we assess the quality of every chest X-ray? We can assess the rotation by the clavicular two clavicular heads. We can assess the inspiration or depth of inspiration by the counting the anterior ribs and posterior ribs. And also we can use a marker which is can direct us and guide us for the direction. And we can assess the vertebral bodies for exposure. As we mentioned before, it should be appeared a little bit, not that much penetration or not that much minimal penetration. This right atrium, as we can see in the this X-ray, yellow arrows showed to the right atrium, right ventricle. It cannot appear, it cannot project through the posterior anterior X-ray. This is left atrium. This is the left ventricle. This is the aortic knob or aortic arch area, and this is descending aorta. How can we comment on descending aorta? It can be. We know the discrepancy or the difference in the density or lucency or intensity or echogenicity. All of that we are relying on that on interpreting or reading just radiological image. For that, the lung, it's filled with air, it should be appear as a blackish area. If there is anything in contact with the lung, it will show us there is a well-demarcated area, and this is descending aorta. It can be appear, and we should distinguish the descending aorta from the vertebral body or the left borders of the vertebral bodies. Always one view in chest X-ray equals 0 view. We should have a lateral view, and this is just a demarcation, or we can visualize the anatomical part on the chest X-ray. This is the right atrium, this is the right ventricle, and this is the left ventricle. And this is the arch, this is the aortic arch, and this is the pulmonary arteries. And we can see it, we can inspect it on the lateral chest X-ray. This is the left ventricle, and this is the right ventricle, and this is pulmonary arteries, and this is the aortic arch. On this picture, we can inspect, we can know more about the details of the cardiac parts on chest X-ray. Here also, the same. We are cutting like a CT. We are having a cross-sectional from the image, as we are doing in the CT chest. We are inspecting the heart from down. This is the right ventricle, this is the right ventricle, this is the right atrium, and this is left atrium, and this is left ventricle. We should comment on the hilar area and the pulmonary vascularity. This is the right hilum, this is the left hilum, and the left hilum always higher than the right, which is this is the normal, because the left main bronchus is more horizontal, and the right main bronchus is more vertical, and it should draw V-shaped. The pulmonary vessel, it should draw the V-shaped as a normal situation. We can comment. Then we will talk about the lung and the airway marking. This is also a picture from the CT scan. It showed this is the trachea, this is the paratracheal strip line. The paratracheal strip line, this is the left paratracheal stripe line, and this is the right paratracheal stripe line. And it showed here also the left main bronchus in CT chest. Also here we can inspect the left main bronchus, and also here we can inspect the right main bronchus. Here also we can inspect the right main bronchus, which is more vertical. For that, the most common area to have an respiration pneumonia is the right lower area. This is the carina, which is the bifurcation for the right and left main bronchus, and we can inspect it here sometimes if you have a good quality chest X-ray. Just I want to stress on one point, that the normal anatomical part, the normal anatomical components of our lung is the right lung. We have 3 lobes, and the left lung we have 2 lobes. Why I brought that? Because always we are misinterpreting the chest X-ray as a right lower lobe pneumonia, or right upper lobe pneumonia, or right middle lobe pneumonia, or the same work for the left. This is the right upper lobe, this is the left right lower lobe, this is the right middle lobe, and this is the horizontal fissure, this is the oblique fissure. And the same work for the left. We have left upper lobe and left lower lobe, and this is a horizontal fissure. This is a chest X-ray of patient that present with after a choking attack, elderly. They present with a picture of cough, fever after he experienced a choking attack. As we inspect, there is an obvious infiltration on this area, and we are always misinterpreting this infiltration as there is a right, there is an obvious infiltration or ossification or batch infiltration on the right lower lobe, which is wrong. As we mentioned before, this is also the same. As we mentioned before, it should be the right side of the heart is in contact, or the right side of the right border of the heart is in contact with the right middle lobe, not the right lower lobe. And the same here. This is on the right lower loop, not the right middle loop. It can be on the right middle loop, but more on the right lower loop. For that, those things that have a direct contact with the loops, right middle loop, it will be in contact with the right side of the heart, and the right lower loop, it will be in contact with, it will touch the right hemidiaphragm, and the left lower loop, it will touch the left hemidiaphragm and the descending aorta. As we mentioned before here, the right middle loop is in contact with the right side of the heart, and the right lower loop is in contact with the right hemidiaphragm. And the same also here. Left lower loop in contact with the heart, and it's in contact or with the touch the left hemidiaphragm. This is one of the most common misinterpretation of the chest X-ray. We should comment on the diaphragm. This is the right hemidiaphragm. And this is the left hemidiaphragm. We should comment on the descending aorta also. And those lines, as we draw it before, if it should be clean, and it should be obvious. This area is not clean. The diaphragm or the cardiac borders, it means that there is a losing of the air on that area. Losing of the air, either it's going to be filled with a pus, like what we have in pneumonia. It will be filled with the water, like what we have in congestive heart failure. It can be filled with the blood, like what we have in hemothorax or pulmonary hemorrhage. And it can be collapsed area, like what's happening on Atlantis disease, which is very common. The right hemidiaphragm is always higher than the left. And the costophrenic angle, what we call it here, the costophrenic angle. Phrenic, it's mean the diaphragm, because the diaphragm is innervated by the phrenic nerve. For that, we call it costophrenic angle. It should be sharp. It should be well demarcated. It should be obvious. Any bluntation in this area, it's considered as abnormal. This is a summary. What we have been talking about it initially. This is a summary of everything. Before we start to talk about systematic way, المسج اللي بوصل لكم هي you need to be systematic in everything. الابروش اللي دائما احنا بنسويه انه we have what we call geographical approach. بنشوف الchest X-ray from inside to outer, from outer to inner, which is sometimes it work, but we can miss a lot of stuff on that. واللي بسميه هذا الشيء انا دائما انه it's what we call it happy eyes. We will attract to one pathology, then we will neglect the other pathologies. راح اعلمكم على شيء what we call it is doctors ABCDE. Mnemonic, we can be systematic on it. وسهل الحفظ, you can easily memorize it, and we can easily follow it. A sequence, it's so easy. We will talk about it. D stand, mnemonic start by D. D stand for details. Always we are بنشوف X-ray وما تكون البيشنت هذا, بتكون البيشنت ثاني. Please check for the patient name, patient age, date of birth, and sex of the patient. And we can see this is the BA view or AB view, erect or spine or whatever you have. Date and the time of study. Why would I mention that? Date and the time of study. It should be in the details, in the details, and we should check it every time, because we are doing multiple series X-ray or radiological image. We do chest X-ray, then we intubate the patient, then we will do chest X-ray. Later we're gonna do a central line. We're gonna ordered chest X-ray. For that, the date and the time of study is so crucial and so important. R for the ripe. We should ripe our image. We should assess the quality of our image. As we mentioned before, rotation, the two clavicular heads or the medial clavicular ends it should be equidistant from the spinous process. And the inspiration, as we mentioned before, at least 5 to 6 anterior ribs and 8 to 10 posterior ribs. The picture, we should assess the fullness or the completeness of the chest X-ray. It should be including, as we mentioned before, the clavicle, bilateral clavicle. It should include the shoulder, part of the humerus. Also, the exposure. E stands for exposure penetration. We should assess this chest X-ray, and we should say, and we should comment on the penetration for of the beam, as we say, by inspecting intravertebral disc space, or it should be the spinous process. It should be appear up to approximately the thoracic vertebrae number 4. The soft tissue and bones. احنا دائما we are missing the soft tissue. For that we include it early on DRS. S stand for soft tissue. We are always missing it. Please keep it in your mind. The soft tissue is so important in interpreting or reading any chest X-ray. We should look for the symmetrical, the symmetry of every part. We should look for if there is any swelling, if there is any loss of losing of the tissue planes, there's any subcutaneous air mass, and we should comment on the breast shadow. Bones, it's a crucial part. We should comment on it. Anterior and posterior ribs, the sternal and clavicular area, and we should comment on the if there is any deformity, dislocation, if there is any fracture or asymmetrical shape. A stand for airway and the mediastinum. Airway starting by the tracheal area, paratracheal and mediastinal, paratracheal stripe line, mediastinal mass, also right main bronchus and left main bronchus, and the carina. And we should assess the mediastinal width, which is always we are doing it in a wrong way. It should be done in different measures, like in the sitting X-ray, it's totally different the number from the supine X-ray. Aortic knob also, and the hilar area, we should comment on it, on the area and mediastinum. This is for the A. B, for breathing, we should comment on the lung fields and the pleural. We should comment on the lung fields from up to down and from inner to outer area of the lung. We should comment on the apical area. We should comment if there's any element of pneumothorax. We should comment on the lung field, horizontal fissures, infiltration, foreign body, cavitary lesions, or if there is any obvious abnormality on the lung. The same for pleura. We should assess for the thickening and the reflection of the pleura. C stands for circulation, which is the major part on our chest X-ray. Chest X-ray is not just for the lung. It's give us a good interpretation about the heart function, the heart size, the heart borders, and the shape and position. For that, the heart position, it should be 2/3 of the heart position on the left side, and 1/3 of the heart part, it should be on the right side. The normal heart size, it should be measured after we can measure it from the cardiothoracic ratio and just BA few. The normal it's below 0.5 or the half of that chest. The cardiac size it should be half of, at least less than half of the thoracic or the thoracic diameter. The heart border, we should comment on it. It should be well demarcated. The heart shape and the aortic stripe area, or what we call the aortic nerve. The diaphragm, it's a crucial part. It's a paramount part in every chest X-ray. We can comment on the right hemidiaphragm and the left hemidiaphragm. The right is always higher, and we should comment on the shape of the diaphragm, costophrenic angle and cardiophrenic angle should be clear, should be well demarcated. A gastric bubble, an area below the diaphragm, we should comment on it, as we can evaluate the pneumoperitoneum or air under the diaphragm by chest X-ray. E stand for extra. Extra for ATT, endotracheal tube, central line, NG tube, big line, monitor electrodes, ECG electrodes, pacemaker, ICD, chest tube, whatever. E stands for extra. Everything is extra. And this is just a summary of what we mentioned before. Doctors ABCDE for a systematic approach for reading any chest X-ray. I want to stress in small points. في area كتير we are not attracted to that area. We are not giving that area good attention. We are not doing a good evaluation for that area, and this is a commonly missed area, which is the bilateral apical area and the retrocardiac region and the area behind the diaphragm and the peripheral area of the lungs, or the peripheral region of the lungs, and the hilar area. Those are the most common missed area on chest X-ray reading. Always one view equals 0 view. We should comment on the lateral. We should do 2 views, not a 1 view. Always. ليش نحن بنقول انه systematic approach؟ لانه always لما نحن بنشوف what we call it geographical approach, inner to outer or outer to inner, انه we will be attracted to one pathology. We will be what we call it happy eye when we catch any pathology. Then we're gonna stop. Always in medicine, في الطب, look for another pathology. The most common missed disease in the world is the second disease. For that, look for the second pathology. Look for the second abnormality. Do not be attracted. Do not have the happy eye with one pathology. The systematic approach is useful for who? For the least experienced clinician. يعني مو شرط أن تكون radiologist عشان to read chest X-ray. No. You can have a systematic approach. You can follow it. It can guide you. It can be easily to be followed. It can include all the aspects of the chest X-ray, from upper to lower, from inner to outer, from outer to outer. It can include everything. But please remember, there is no one best system. You can follow whatever you want to follow, but please be systematic. For that, you will not miss anything. Let's talk about some cases. This is an 18 years old female patient present with the right side pleurotic chest pain. أنا ماني شايف الشات. For that I cannot comment. I cannot interact with you. But I can give you just a second to evaluate the chest X-ray. It's obvious. Second year medical student, he can interpret that. How can we discover the pneumothorax, either traumatic or spontaneous pneumothorax? The interstitial tissue, what we have it here, it's not well appeared on the right side. We can say we can evaluate this is the right, this is the lateral border of the lung, which is a right lung. It's totally shrinked or collapsed. Losing of interstitial tissue in one area, it's pneumothorax until proven otherwise, or collapsed area with this area until proven otherwise. Other than this is another case. Healthy young female with a sudden onset of right side aortic chest pain.
دكتور
Yes.
تسمعني؟ طيب
Yes.
اوكي، اللي عارف الجواب ممكن يكتب في الكومنتس و I will show الكومنتس للدكتور.
Perfect. Perfect. أنا ماني شايف الكومنتس but احنا ما
اوكي سكرين طلعت لك.
لا ما طلعت لي ابدا يعني، بس ممكن
اوكي
نشوف.
one of the comments كانوا قايلين pulmonary embolism 2
Yes.
3 أو في شخص كمان كاتب pneumothorax.
Perfect.
BE
Perfect. It's البي اي دائما فيها radiological findings في التشيست اكس راي، لكن it's rare like what we have in Hampton Hams or Westermark، بس السبيسيفيستي حقتها كلها not exceeding 50%. ف we cannot rely on that chest x-ray. لكن مو شرط النيموثوركس دائما انها تكون عندنا to be appeared in a good way. فلو لاحظنا هنا اليوسنسي حقت والانترستيشال او الدنستي، هنا الانترستيشال تيشو او الانترستيشال لانج تيشو it's not appear here. ف this is what we call it as a pneumothorax, but ما هي clear زي البريفيس x-ray. keep bear in your mind not every pneumothorax is appeared. شايفين اللنج بوردرز واضحه تماما هنا، والليوسنسي حق والدنسيتي هنا مختلفه عن البقيه اللي هي الانر بارت. فالانترستيشال تيشو عندنا it's not well appeared زي ما هو هنا في it's not reaching the lateral borders or the lateral edge. Which findings is present on this X-ray?
نعطيهم وقت شوية يفكروا.
يلا. I think it's enough. أنا شايف الشات.
I will read. طيب. One of the comments say that pneumonia.
Perfect. فأي لوب.
Another comment say that opacity in the left side of the lung. Third say that left lower lobe consolidation.
Perfect. As we mentioned before, إنه left lower lobe, it's in contact or touch the left border of the heart. But this is most likely a left lower lobe pneumonia. دائما احنا بنقول لو كانت الانفلتريشن is here, we call it, لو كانت هي, we call it the right lower lobe pneumonia, which is wrong. This is the area that we have a contact between the right side of the heart and the right middle lobe, and the left, the right lower lobe is in contact with the right side of the hemidiaphragm, the right hemidiaphragm. ما هو necessary انها تكون في lower area, it's mean on the right lower lobe. This is the lateral view for the same patient, which is give us a good visualization of the retrocardiac area, and would give us a good hint about the retrocardiac area or the retrocardiac infiltration. For that, ordering a lateral chest X-ray is so crucial and so important. Which finding is this? What we call this sign? Chest X-ray? Comment?
There are comments. meniscus
يا سلام يا
sign,
سلام
meniscus sign، ما شاء الله كلهم بيجاوبوا.
خلاص.
هذه أصلا كانت الصورة حطيناها أمس.
انت حطيتيها امس؟
Yes.
فاكتشف يعني خلاص
لا بس لسه لا ما جاوبنا.
Yes. بس انا ما I cannot see your comments. وردان she gonna deliver comments, كل comments to me. This is what we call meniscus sign. It comes always with the pleural effusion. It's not always, but it's pathognomonic for pleural effusion. What we have on this chest X-ray.
One of the comments say that air under diaphragm.
Perfect.
ما شاء الله.
The chest X-ray of a patient that underwent for splenectomy, and it showed why I brought this X-ray, because the area under the diaphragm is so crucial area. It's a paramount area. We should comment on it. Chest X-ray is not only for the chest; it's including the area below the diaphragm, which is always missed area. ما راح تجيكم air and diaphragm زي كذا واضحة و obvious و clear. Sometimes it's gonna be just rim of air. How can we discover إنه هذه gastric bubble ولا air and diaphragm؟ الديماركيشن حقها. الديماركيشن حق ال air and diaphragm is well demarcated. بيكون نفس الكلام زي كذا. والديماركيتد اريا شارب نفس الكلام. not مو زي الجاستريك بابل. it will not be that much demarcated. We can differentiate between those area that filled with air. ما حبيت اطول جدا، ابغاها مره انه second year first year nursing الاي ام اس الار تي، اي احد يقرا يكون يستفيد من المحاضره. وعشان اللي لما يشوف احد في اليوتيوب ما يشوف انه المحاضره تكون ساعه ونص، تكون سهله الهضم عليه، وشيء يعني بسيط يوضح لنا البيزك anatomical part of chest اللي بنقراها في الاكس راي. For that I brought always in my lectures I brought my reference, I brought a recommended reference or recommended websites. هذا واحد من الويب سايتس الجميل جدا اكتشفته مؤخرا، teaching medicine جميل جدا في الاي سي جيز، في الاكس راي. راح يعلمكم الاكس راي من A to Z، وجميل جدا. الليفل حقه بيزك تو مودريت، جميل جدا. راديولوجي بيت ما عندي اي انا ما اعرف القائمين عليها دكتور عجلان الا بسلامتهم، بس انه انا من شبيحه الراديولوجي بيتس. احب دائما اسمع لهم واشوف لهم في اليوتيوب. highly recommended channel, you should subscribe for it. من اول وانا ميديكال ستودنتس دائما بسمع لهم وبشوف لهم يعني دائما. You can scan it with your mobile, you can capture screen, it's gonna guide you to channel في اليوتيوب. راديوبيديا يعني من اشهر المواقع، معروفة جدا 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 جدا، بل هو ممكن اشهر موقع عندنا في العالم يعني في راديولوجيكال ايمج، وفي a lot of editors فيه. المستوى فيه اكثر من كورسز فيه، بس انه في المستويات مختلفة تماما من beginner to advanced to so professional و expert. اللي ما يعرفه he can scan الباركود، it's gonna guide him there. life in fast lane هذا في 150 chest x-ray interpretation و reading و pathological image. يعني majority of that image من ال emergency departments. ماني بايس، بس انه you can scan it, it's good website. I think انه احنا وصلنا للختام على التايم بالضبط ساعة عشان نستقبل أسئلتكم، عشان الناس اللي بيشوفونا في اليوتيوب ما يقولوا لنا محاضرة مسجلة، عشان ما نطول عليهم. لأي أسئلة لأي أشياء we can الحين we are receiving the questions. anyone who want to contact me, this is my business card, just scan it. You can reach me سواء to arrange for lectures, to arrange for anything. I'm willing. وهذا مو هو هذا الشيء احنا ما بنسوي تفضلا منا او منا ابدا. هذا زكاة العلم التي لابد ان تخرج من كل ذو علم، حتى لو ما احنا ما اتينا كلنا من العلم الا قليلا. فكل العالم هذا كله ما شفنا من العلم الا شيء بسيط جدا جدا جدا. فاحنا حتى ما اعطينا من العلم القليل هذا الا قليله. الله يزيدنا ان شاء الله وياكم علم، ويجعلنا بنأدي زكاة العلم بنشره وتعليمه. أنا أستقبل أسئلتكم. I can see the chat but I can solve it. وجدان في أسئلة؟
أيوة دكتور. There was a question. How can I know which side the patient is in the lateral X-ray?
لما الماركر this is a good question. في اللاترال اكس راي بنشوف الماركر لما يكون الماركر toward the left الليفت او الرايت، احنا بنعرف انه البيشنت هذا جاي البنتريشن من الليفت. لما يكون في ال ليفت ماركر فوق بيكون هذا البيشنت most likely البنتريشن من الليفت. the same work. احنا لما بنقول هذه بي اي فيو واي بي فيو، البي اي ايش بيكون الكاست قدام البيشنت in contact with the anterior aspect of the chest، والبيم تيجي من ورا from behind the patient. هذا بي اي. الاي بي the same بيكون الكاست behind the patient back، والبيم بتيجي من in front of the patient. the same لما تكون البيم جاي من الليفت بنحط هذا من الليفت، لما تكون البيم جاي من الرايت the same work. الدايفرام we can comment على الدايفرام من نفس المكان، ويكان الانتنسيتي حقت الدايفرام دائما احنا بنشوف الرايت هيمي دايفرام higher than left diaphragm الليفت هيمي دايفرام. فلما نشوف الدنسيتي حقتها مور بروكسيمال زي كده بنقول انه هذه left or right.
Another question. He said that if I don't have the markers.
بايش؟ في الليفت؟ في اللاترال؟
في اللاترال.
والله I cannot specify my answer now. بس الماركر دائما crucial يعني to be on every X-ray. البوردرز حقت الهارت we can comment we can evaluate انه هذه right ولا left، لكن I cannot specify an answer لو ما في markers.
تمام دكتور، شكرا جدا على قبولك الدعوة.
أنا أشكركم جدا، أتمنى إنه كنا خفيفين شوية عليكم ومضينا وأعطيناكم شيء من المعلومات المفيدة. شكرا لكل شخص أعطانا وقت من وقته من ثمين أوقاته، أعطانا جزء. نعتذر عن أي تقصير، مليئين بالتقصير. نستفيد منكم زملائكم، نستفيد دائما بمشاركتكم في أكثر من جزء، في أكثر من شيء. سعيدين جدا بأن نكون معكم. الله يكتب لكم الخير والأجر. شكرا وجدان، شكرا لكل من أعطانا وقته. أعتذر منكم أولا وآخرا. الله يزيدنا علم إن شاء الله ومعرفة.
اللهم آمين دكتور. يبدو أن الأسئلة ما حتوقف لأن كمان استقبلنا على سؤال ثاني. كان في سؤال إنه can we see vertebral spine in AB view؟
Yes we can. ال AB view we can، بس البنتريشن حقتها ما هو that much، لكن we can see. لكن it will not appear or it will not be clear like ال BA view. ال BA view بتبين لنا أوضح. ليش ال BA view أفضل من ال AB view؟ لأنه ال BA view ما بصير لها اوفر ماجنيفاينج للهارت ولا الستراكشر. البيم بتيجي وتقدر ريتش الكاست بسرعه، فما فيها اوفر ماجنيفيكيشن للهارت. يعني البيم بتوصل على الهارت على طول بتروح للكاست، فبتعطينا ريل بوردرز وريل سايز ولا ديماركيشن ولا دايمترز حق الهارت مثلا. نفس الكلام في الاي بي والبي اي. وي كان لانه البيم بتوصل للفرتبرا وتكون قريبه من الكاست، لكن البي ايز بيتر ذان الاي بي بمراحل كثيره جدا، لانه بتعطينا ريل dimension, real size of the heart, real size of the bone structures, but we can see it في الاي بي. بس ما that much يعني obvious زي البي اي.
تمام، إن شاء الله يكون جاوبنا. شكرا جدا دكتور على قبولك الدعوة، وشكرا جدا على المعلومات الثرية اللي شرحتها اليوم. إن شاء الله الكل استمتع واستفاد.
شكرا لكم. اعتذر مرة أخرى عن أي تقصير. لو في أي أسئلة أو أي حاجة you can reach me, you can reach حساب فن الاستذكار. الله ينفعنا وإياكم إن شاء الله. كل ما فيه خير بإذن الله، كل التوفيق بإذن الله.